All right, thank you everyone for joining us for today's South Texas Regional Family Medicine Grand Rounds. Our educational partner is the South Central Area Health Education Center, and our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. There we go. Thank you in advance for muting your microphone once the presentation begins, being attentive to the presenters and engaged in the session, keeping your cameras on when appropriate, registering for CME credit for each session, and for completing and submitting a session evaluation form. Today is April 3rd, 2024, and the activity code for today is 10093243. You can claim credit for this via the CME credit via text system. You can text 844-502-1338, text attend, and the number on the screen. Again, that's 10093243, and you must register for each session by midnight to receive credit. Here's some information about that new CME credit system. So I'll let that sit for a minute. Again, the activity code for today, April 3rd, 2024, is 10093243. All right. Here's some information about how to access your CME transcripts from the Long School of Medicine's CME office. And here's some information about the American Academy of Family Physicians credit claiming. This live activity, the South Texas Regional Family Medicine Grand Rounds, has been reviewed and is acceptable for up to 1 prescribed credit by the AAFP, and physicians should claim only the credit commensurate with the extent of their participation in the activity. The Family and Community Medicine Grand Rounds address the following nationally established physician core competencies: the Institute of Medicine core competencies, the ABMS ACGME competencies, and the AAMC competencies. Our speaker today, Cynthia Lopez, MD, has no financial relationships with ineligible companies to disclose. And now our speaker will be introduced by Dr. Nato.
All right, well, good afternoon. It's a pleasure to introduce Dr. Cynthia Lopez. In August of 2013, Dr. Lopez joined the faculty of the Division of General Pediatrics at UT Health San Antonio, where she holds the rank of Associate Professor. She supervises residents and medical students in pediatric residency outpatient clinics and develops teaching modules on mental health, asthma, toddler care, medical home, and healthcare transition. She's an active member of the Texas Pediatric Society Mental Health Committee since 2014 and currently serves as co-chair. She has led several sessions on mental health at the last 2 TPS annual meetings. In 2015, she initiated a collaborative project with the child psychiatrist to allow pediatric residents to evaluate and treat residents with ADHD, anxiety, and depression. Over the next year, she developed a curriculum to increase knowledge and comfort level of residents in treating mental health disorders in children and adolescents and producing packets of evaluations and management of ADHD, anxiety, and depression, as well as implementing a validated suicidal risk assessment protocol in her clinics. During 2018, she served as clinic champion for the Integrated Behavioral Health Pitch Program from UTSA, which provided a welcome second-year provided a welcomed second-year trainee to offer same-day evaluations and counseling within the clinics. When the program ended, she incorporated AAP tools to facilitate interaction between patients and families and physicians when discussing mental health concerns and initiating patient introduction of basic cognitive behavioral exercises. She was also asked to review a Texas Health Steps online provider education child and adolescent depression module in 2022. She currently serves as the mental health liaison between the pediatric residency clinic and the faculty, and a new co-located LCWS providing counseling services to our patients. So it's a pleasure to introduce Dr. Lopez. She's going to talk to us about ADHD evaluation and management in primary care.
Hello. All right, let me see if it can work, please. So that's our topic for today. Thank you for allowing me to speak to you guys. I was just hearing about your program. You may, I forget, this microphone is more for out there, and you guys in here may have a little trouble. Just raise your hand if I need to speak up, but I don't speak up much louder. So if you want to come this way, I'm okay with that as well anytime during the talk. It sounds like you guys already do a lot of this and you have behavioral health clinics as well. So hopefully this will be a little review and show you where some of the kind of evidence comes from. You guys can do some teaching for us one of these days as well. Our objectives today are just learning like where to find different tools that you can implement for the evaluation of ADHD when a child presents with symptoms, including inattention or hyperkinetic activity, and then to select appropriate evidence-based medications and behavior therapies, and then talk about some other free resources that you can use in the management. And I hear you guys are already using some of those as well, so congratulations. So we'll start with the basics. And do you guys know Dr. Pliska? Okay, so he did he had this big work group that they went through a lot of the evidence way back when in 2007. And that's actually the last update from the American Academy of Child and Adolescent Psychiatry. And then the AAP has some other ones that we're going to talk about. But in his article, basically he discusses how ADHD is the neurobiologic condition, very valid. Before we started treating all this, everybody would say, it's all in your head. But yeah, technically it is, but it is a very valid condition that impairs executive function, inhibition, vigilance, affects working memory and planning in a lot of these kids. Functional neuroimaging will show a difference in the brain volume. There's a decrease in the cortical, white, and gray matter, as well as the frontal lobes and temporal lobes as well. So instead of having, when kids that have ADHD are performing certain tasks, instead of having, inhibitory control, there's actually brain activation that is visible. We don't use any brain imaging to diagnose ADHD, but it was good for the research to show that there's differences as well. So there are at least seven chromosomes and at least 8 gene loci that way back when those studies were done before 2007 were shown to have some contributions to really, it's a multifactorial and genetic condition. It were different dopamine receptors, as well as dopamine transporters, serotonin receptors and transporters, which is why we use some of the medications that we use, as well as non-genetic causes, perinatal stress, low birth weight and prematurity, of course, traumatic brain injury. I'm sure you guys have seen maternal smoking may contribute, as well as severe early deprivation, but it has to be pretty severe in order to increase ADHD symptoms. So the incidence, it will depend where you live, basically. Some parts of the United States have more than 12% ADHD diagnoses, and some have as low as 7%, also depending on, socioeconomic factors as well. Because it is very complicated and people use different ways of researching, it's hard to tell what percentage will continue to have symptoms into adulthood, but a very good percentile will, which is why the DSM-5 took more into consideration while managing adults as well, as opposed to the DSM-4 also. So yeah, young adults may still be on medication, and then you guys may actually end up treating these folks. They still all got started fairly young, but may not have necessarily had the diagnosis, or if they did have the diagnosis, they will continue to have symptoms. In comparison, the incidence of asthma is about 5 to 10% as well, so at least as prevalent. So screening, so who should be, and ask our residents, who should be tested for ADHD? You can do regular screening just during your well child check, asking about, impulsivity, hyperactivity, really just asking how's school going, something like that as well. As far as the impairment, you can use a general screener like a pediatric symptom checklist for screening kids from 4 to 16 years of age. But really, anybody who comes in, the parents, and this is usually the complaint, is that they're having trouble at school. Either they're very active, or they're having trouble getting them to pay attention. And that's, I think, the most frequent way. And sometimes it's the teachers that are bringing it up, and sometimes it's the parents. Okay. Just because a child can sit in your office, and this is what I hear from the residents, and I have to remind them all the time, just because somebody can sit in your office and not show you any signs of ADHD doesn't mean that they don't have ADHD. Children do very well in the one-to-one with novel experiences, paying attention and focusing on somebody that's talking with them directly as well. So those kids should still have an evaluation. Okay, so the DSM-5 criteria are there. We'll just go over a few of them. The first part is the first 9 are inattentive symptoms, fails to give attention to close details. They have difficulties sustaining attention in tasks or play activities. They don't listen to you. You're like talking to them directly, and they're like off to the side, paying attention to something else. And the problem is, not following through on homework or chores that they need to get done, or older folks, finishing their job tasks. Difficulty organizing, they don't seem to get engaged. They're often losing things. They lose their homework. They lose a pencil to do their homework. And again, are being distracted a lot and forgetful. For the hyperactive, I think pretty much everybody knows what these kids look like. Tell parents, we all have symptoms of ADHD. The problem is not necessarily just having the symptoms, it's having the other things that go along with it, the impairment as well. This looks like one of my siblings' report cards. So-and-so is a very good student, but they won't sit in their chair. They're little social butterflies. They have lots of friends in the classroom, but they won't sit down in their chair, running around in the classroom. They're always on the go or driven by a motor. The parents will often say that, the teacher will often say that, and of course, excessive talking. Okay. The impulsivity, often blurting out answers before you even finish completing the questions, and they can't wait their turn. They're often interrupting others. So in totality, within the DSM-5 criteria, symptoms have to present before age 12. In the DSM-4, it was before age 7, so that did get bumped up. You have to have at least 6 of the symptoms in either of the categories, either the hyperactivity, impulsive category, or the inattentive category, or both. And if this is an older teen that started having symptoms again before age 12, but they're not presenting until age 17, 18, they only need to have 5 of the symptoms instead of 6. And of course, it's a chronic, lifelong, or at least early on issue, so it has to be present for over 6 months. Okay, you'll get those, the 18-year-old or 17-year-olds that have been having issues for a month or 2, or when they're transitioning to college or something like that. So that would not be ADHD per se. You want symptoms to be present in 2 or more settings, which is usually at home and then somewhere else. Sometimes it can be at grandma's house, or it can be at daycare if they're not in school yet. Other than that, most of ours have issues at school. If they're older, at work as well, or after school sports, things like that. That counts as second setting. And then there has to be some interference with function and the quality of life, social activities, school activities, or work function. Other than that, I think, again, we all have symptoms of ADHD, but not the disorder. And of course, it can't be due to schizophrenia or another psychotic disorder, or purely because of anxiety. We're going to talk about comorbidities, but it's one of the things that we're going to discuss in the differential. In the past, kids with autism were excluded, but in DSM-5, the autism is not an exclusion for treating kids for ADHD, so they can be, again, a comorbidity. So the difference between the guidelines, the AAP started talking about this in 2000. They had their first report, major report, 2001. They started talking about treatment for ADHD, updated in 2011, and between 2011 and 2019, which is the last updates, there was DSM-5. Bigger focus, I think, in there, just between like a differential diagnosis in those. Otherwise, it wasn't too much of an update. So, this is like, everything, right? You have to do everything. You have to talk about everything. And so this is why I'm going to show you the little chart that I'll show the parents in a second, why I'll show them that chart. It shows you everything we need to go through and to get through the differential diagnosis to say, yes, this is just basically bread and butter ADHD, right? So you need to go through the whole history. You want to go through, see if they have more anxiety than ADHD symptoms. Was there any history of severe head injury? Are there any signs of hyperthyroidism on your physical exam? Or could this be a possibility? Lead intoxication. It's not very useful to check for lead after the fact, but an acute episode, again, that would not meet criteria for ADHD. If this is an acute event, right, you'd have to have at least a 6-month worth. Kids with ADHD may have had a high lead level in the past, but it's usually not the cause of the ADHD. And certainly when you're checking them later on, when they're otherwise doing well, you're not going to get an actual high lead level. But if it's an acute, the lead intoxication can cause some symptoms of, inattention, hyperactivity. Fetal alcohol syndrome, trauma, problems with vision, problems with hearing. There's a long list that you have to go through, which is why you have to be very careful in your history taking in your exam. Comorbidities, we'll talk a little bit about, and we're going to talk to how you assess those in the screeners. I don't really see, 80% oppositional defiant, and it really depends on the study what you come across with. I'd say probably it's closer about 35% for oppositional defiant, probably more of language or learning disorders, at least 35 up to 50%. So that's probably the highest. Comorbidity, substance use, and smoking is another one as well, up to 19% that I took off of there for some reason. Anxiety, high numbers, yes, up to a third. And then depression disorders are still always about 20% in most of the studies that are comorbid with them. Let's see if there's any other notes. So this is the evaluation, and it tells you, it comes from the algorithm on the explanation of process of the care for evaluation of ADHD in children and adolescents. So especially a lot of times these families will come in crisis after they've been kicked out of daycare for the 3rd time, or they're failing some classes. And especially they'll come, when they're 8 years old, and I've never seen them before in my life. So this is when I'll pull out my little handy chart. It's like, okay, so we're going to get to know you. I appreciate you coming in and sharing these concerns with me, but we need to kind of go through the process of evaluating and showing them kind of at the, top to the bottom, how many steps it takes. Usually it'll take about 3 visits before I'll do a diagnosis of ADHD, especially if it's somebody that I don't know. I've done it in as few as 2 in those kids that can be very much a danger to themselves if they're not treated. Basically, the top row just kind of starts with, and you don't have to worry about the details, identifying somebody who's got the symptoms of ADHD. The second area is what you do, the diagnostic evaluation, looking for signs of ADHD and comorbid conditions. Step 3, which is basically the next row, if you're just kind of going down the line, do they meet criteria, the DSM-5 criteria? So you go through those. Step 4, working more in detail with comorbid conditions. And then depending where you are, down step 10 is the second to the last row. That's when you actually get down to treatment of medication. So I don't mean it to be a scare tactic. I just want somebody to realize that this is going to take me a few visits to get this diagnosis correct. Okay. Because again, you may be giving them a lifelong diagnosis. So evaluation, of course, you're going to interview the parent and the patient. You want to get information from the schools or the babysitter or the school coach, along with the parent or guardian. And you want to use validated screeners. We're going to talk about one that we use more specifically, but where you can find others. And then sometimes you have to evaluate for other psychiatric disorders, which are part of sometimes some of the screeners, but you can actually definitely go into a lot of detail, or by that point, I'm usually referring out if I think there's something else going on. And then sometimes, you know, a lot of the social situation is contributing to what's going on. So again, have to take time to get that history, which, you know, requires some sit down face-to-face time with the family, with the child and without the child in the room. And of course, you need a complete physical evaluation with including the hearing and the vision screen. I did have one little girl that, yeah, was kind of an acute thingy for the past 2 months, had been having inattention, and yeah, she couldn't hear out of either ear. That's always important. So sometimes you've already done like the well child check, and that's good. So you've got all that marked off. So it kind of cuts down your visits by a little bit, but a lot of time, again, they're coming in. We get a lot of these kids from the community where we aren't the PCP. And so we have to kind of get to know them and get their records. The red flags, again, the one that speeds up my timeline for the evaluation is kids that can be a danger to themselves. They won't wear their seatbelt, or they get out of their seatbelt, or they try to open the door in the car, run out in the street. That I might get you evaluated the same week and in 2 visits, at least get you started on something. Older kids, again, that have been trouble with the authorities, and of course, if there's any suicidal ideations, which is good, especially as they get older, to do, you know, other mental health screens when you're doing these screens as well. And then has there been violence or aggression or antisocial behavior? And of course, very concerning would be a history of abuse. And there's different kinds of abuse. So the Vanderbilt assessment scales, do you guys use those? Yeah. I like them because they're nice, validated screens. And down at the bottom, you've got the address. Usually you can just, you know, Google mental health tools for pediatrics from the AAP. They have like a 30-page document they update every couple of years on comparing screeners. And so we've compared some of the screeners. The validity we thought was, and the reliability for these was really good, and they're free from NICHQ. And you can get the 2nd or the 3rd edition. This is the 3rd edition. 2nd edition is free. 3rd edition, you can tell it's a 3rd because it's got little blocks instead of little circles. 3rd edition comes as part of the AAP toolkit, so you have to buy the toolkit. Even the AAP says there's not a big difference between 2nd and the 3rd edition. Just make sure you're using the right key to score each one, because the numbering is a little bit different. So if you want free, use the 2nd edition. If you buy the AAP toolkit, which is just over $100, then you use a different key, and this is what it looks like. Again, so the way the Vanderbilt, if you guys use it, you know, the first 9 are for inattentive symptoms, the second 9 are for the hyperactive impulsive symptoms. The top of the next page, they're screening for oppositional defiant symptoms and conduct disorder, and then they're screening for anxiety and depression. The Vanderbilt is not a great screener for internalizing symptoms. So that's why you might use like a pediatric symptom checklist, or do something specifically testing, checking or assessing for anxiety and depression. So again, this is not the greatest for that, but it's just like a little mini screen within the screen, basically. And then the last part on that 2nd page is seeing what the impairment is in specific subjects, right? So everything gets a number. Positive scores are the last row, or 2nd to last row. That gives you your 2s and your 3s. You have nevers or zeros. Occasionally is the 1, and then more often is 2s and 3s. So the positive scores are 2s and 3s. That's how you score that one. So it's pretty easy to go through. You know, if you had 6 2s and 3s on the first section and 6 2s and 3s on the next section, then you would then you go through and you review if you've got the DSM-5 criteria. Has it been going on more than 6 months? Is it this is for the teacher, this is for the parent, are both of them positive, and it's going on in at least 2 settings. You're looking at the end for the impairment. Is there impairment? Do you have 4s and 5s in your impairment in at least 2 areas? Then you would meet the DSM-5 criteria if the symptoms started before 12 years of age. So after you do these, right, they're pretty easy to mark off and score. I think this is one of the easiest ones to score once you do that. So this is the scoring, and like I said, make sure you use the right one for which one you guys are using, either the second or the third edition. And this is what I just said. So it changed, the wording just changed from DSM-4 to DSM-5 on presentations rather than subtypes. Combined is if you get, 6 and 6 of both sections, or predominantly inattentive, it's just 6 out of 9 positives on the inattentive, or 6 out of 9 as an impulsive, hyperactive, basically. Then you can have mild, moderate, or severe ADHD, just depending on how many symptoms are positive. And some people like to do that. I'm happy if I get the diagnosis. In the back of the key, you can also, again, add all those points and score if you like to keep track of that as well. I don't usually, I just count the numbers. Okay, so there is no diagnostic study that you need to do. Like I said, if they did have a high lead level, then by the time they're presenting to you, usually it's a lot later and their lead is actually normal. If you're suspecting a low IQ, though, you should probably do testing for that, and usually I get that done through the school. So as far as the evidence, the 2019 guidelines from the AAP, this is the evidence that they use. Everybody's are usually, you can't see my cursor, about the same, basically. Of course, A would be the best evidence with randomized control studies, and going further down is more, case reports or expert opinions. So just remember, A is good, B is not bad, still pretty good, and X or D would be less rigorous studies. And in the article, it's maybe about 20, no, it's about 19 pages of reading if you ever go through the AAP article, and then it's just resources after that. You can kind of go through this pretty easily if you need a little bit more convincing on the evidence, but we're going to go through, what time are we? Okay. We're going to go through some of the grades of evidence that are on the guidelines. They go through and they give you 7 or 8 action statements. And we're starting with the treatment, starts with 5. So what are the recommended recommendations and level of evidence for treatment of ADHD by age? So we're going to go through preschoolers, which are usually 3 to 5 year olds, basically. They have a grade A or strong recommendation for PTBM, which is Parent Training in Behavior Management. So grade A for that. So that would be the highest level of recommendation, doing that first. Grade B or strong recommendation for medication, specifically methylphenidate is the one that they mentioned, if they don't improve after doing the PTMB, basically. There's very few children, again, at this age that I start on medication, except those that are, again, the jumping out of the car. They literally have patients do that and run in the between cars in the parking lot, things like that. So that might be somebody that I would start sooner rather than later, but almost all of them I recommend that they start with the behavior management. For the older kids, medication works best. Starting that first and then adding the training would be a really, really great adjunct. So the combination is going to work best of all. And you can include also like the behavior classroom. So the behavioral intervention also include classroom adaptations that can help children with ADHD function more effectively. These typically fall under the Section 504 guidelines that were originally designed to prohibit discrimination against children with disabilities in the school system. Do y'all know what CHADD is, or CHAD? CHAD.org has been around for many years. It's for families of children with ADHD. They have a lot of resources on that website. So it's CHAD, CHADD.org. They have good resources for caregivers talking about, the 504 and then IDEA. The 504 accommodations can include preferential seating, a modified assignment and homework load, breaking longer assignments up into smaller manageable chunks, and then like reward charts and things like that. Using visual cues to remind kids to stay and giving them more breaks. This might be the kid that you let, get up and clean the erasers or sharpen the pencils or something like that, every 30 minutes. And their tasks need to be 15, 20 minutes instead of the 45 minutes that the other kids are. And most of the schools, if they have that diagnosis, will do that. Not all of them. Sometimes I've had to write out these things explicitly for the families to get that. So there is, okay. And then for the older kiddos, the 12 to 18, the quality of evidence A or strong recommendation that you should prescribe FDA approved medications with the adolescent's assent. There's grade A or strong recommendation also for training and behavioral treatments for ADHD with the family and the school. And you're encouraged to prescribe that kind of evidence-based training, bless you, as treatment for ADHD if it is available. These are kind of harder to get into a lot of the times, thanks to a lot of the stuff that the consortium is doing, the one that has the CPEN and all that set up. There are some programs now in the schools that they can get through. More and more of the San Antonio schools are getting those. So I always ask the parents to see if they have like the T-chat available through the school. Okay, as far as for non-pharmacological interventions, I have some good articles on this, going through a lot of non-pharmacological interventions that parents will bring to you. And I give that to residents as a resource, because at some point somebody's going to tell you, I want this computer program for my child, or can I try, a high zinc diet, or, high iron, or things like that. And so I give them basically what the evidence is for each of those, but there's nothing to support that dietary modification will make an improvement in kids with ADHD, or not enough data for the EEG feedback. And CBT is not the therapy that we want. It's a different kind of therapy. Still therapies, but not CBT. CBT is more for your anxiety and depression. And then, do you guys do this in your clinic with your behavior health clinic? Any of the behavior therapies? You'll get to see that. Yeah. So it can be kind of quite intense. We finally got somebody to help us out at our clinic to do some shorter sessions, but people do up to 10 sessions, and we just got hit in December. So typically they're 10 to 20 sessions, 1 to 2 hours each, doing how to attend to child misbehavior, the token economy. Do y'all know what a token economy is? I love token economies I think this works best for younger children. There's different ways you can do this very easily yourself, either in the school. Kids with ADHD, everything has to be immediate. So they get points or stickers or whatever it is. As soon as you see a behavior that they're doing that is really good that you want to see, you get whatever that token is, and maybe a little star. And if you collect 5 stars by the end of the day, then you get this reward. And so it has to be concrete, it has to be pretty immediate, and it works very well with younger children, even if they don't have ADHD, but especially for kids with ADHD. They like that rapid turnaround with their reward. And you can do that at home. I do a little Y on the refrigerator, behaviors I want to see, behaviors I don't want to see. And they get, points for behaviors you want to see, and -1 point, and then total up at the end of the day. The kids will tell you that they'll remind you when they didn't get their point. They won't remind you when they didn't do the chore that you asked them to do. But they're really into it. This works well for kids with ADHD. And then doing the school report card, they'll do, was this a green day? Was it a happy face day or a sad face day? Things like that. And then working towards those goals. Teachers and parents find this satisfying. And whenever you're doing behavior therapy is in the name. So therapy is a treatment and medication is a treatment. using both a lot of times will decrease your dose of each, right? So you may not need as much therapy if you're on appropriate medication. You might not need as much medication if you're on appropriate therapy. Okay. Problem is that, the heritability is about up to 70 to 80% from parents a lot of times. So if the parents have ADHD and they're not being treated, then that may interfere with your success. So stimulants. And again, since you guys are doing some stuff with CPAN as well, you might get the little charts that I'm going to show you in a second. We have very good effect using stimulants, and at least 75% of kids with ADHD respond to stimulants. In some studies, it's up to 90%. So if stimulants aren't working, a lot of times ADHD is not your diagnosis as well. Okay. So this one, it's down there. Have y'all used this one as well? The ADHD medication guide. This one comes from Dr. Andrew Aidsman in New York. He was at B&D and he updates this regularly. If you go on there and you click on like an end user agreement, then you can either print one of these out for yourself. We've ordered like mini versions of this for like $3. It's not a profit thing, but they just laminate it for you. But if you're part of CPAN, they send you these. Every year they get updated with the new ones. And now there's a newer version that has this and just the stimulants by themselves. The great thing that you can see is the size of the pill. So you can see if a child can possibly, this little 5-year-old can swallow this, big old pill or not. It shows you whether you can open it or you should not open it, and that would be dangerous. And what the availability is. So it's got a lot of really good information in these cool little charts, and especially where the families can't remember what they're taking as well. But for us, it kind of helps us to see what category, because they'll give you the brand name. It's like, oh, so is that a methylphenidate or is that an amphetamine formulation when you're trying to compare? So I think these are pretty useful. And if you join CPAN, usually they'll send them to you, or you can get them off that website fairly regularly. So this is just some of the amphetamine preparations. There's short acting and there's long acting. The onset of action is usually about 20 to 60 minutes in both of these. The lisdexamphetamine is one of the long acting ones that we use on kids, especially if they have a risk of substance use as well. You can't really get a high when people try to snort these things sometimes. So that's one of them. The ones we use for that. The methylphenidate preparations also short acting and long acting. And lots of different brand names. There's always new ones. There's a Daytrana patch was the only patch that was available. I think there's a new one that's available as well. And some parents love those, but can cause some skin irritation sometimes. And again, onset of action is about 20 to 60 minutes. When you're using stimulants, basically you want to pick one. Yeah, usually you pick a couple that you're comfortable with. We use a couple from each class, and because most of our kids, I guess 70% of our kids have Medicaid, so we know the Medicaid formulary, so you don't have to get comfortable with too many. But you want to pick one. You start low and go slow, basically. Younger kiddos, we tend to start with like the preschoolers or 6-year-olds might start with 2.5 milligrams, let's say, of methylphenidate, and titrate up from there. You need to set the expectation, right? Then you may not feel anything when we start this, and that's our goal. We're just looking for side effects for those kids that are going to have the little creepy, crawly skin sensation, or some kids will get very agitated, especially the younger they are, which is why we don't like to use medication in the preschoolers whenever possible. But I also like to use the short acting first when they're medication naive, especially the smaller they are, because they do last shorter amounts of time. So it'll wear off. If they're having a side effect, it'll wear off in 4 to 6 hours, as opposed to starting with a long acting may wear off in 12 to 18 hours. So that would not be good to be uncomfortable for that long. And then you can always switch over to the long acting once you've got the tolerability. So pretty quickly you can go up to the long acting one. Side effects, And this is, I have like little smart phrases for everything. Typical ones are going to be your headache and abdominal pain. Next ones, those do usually get better. I have some kids that will continue to have headaches, but typically will get better the longer that they're on the medication. Poor appetite and poor weight gain can be an issue with some of our kids. So we have to be creative sometimes with getting them an extra meal at the end of the day because they're not eating enough during the daytime. Sleep issues, although some kids' sleep will get better because they organize better around bedtime when they're on the medications, and some parents would tell you that. Mood lability is a common thing as it wears off. Palpitations doesn't occur very often, but I do think of that as an indication to probably try something different. Blood pressure elevation is not usually something that they complain about, but you may see it when they come in and they get their vitals done. Exacerbations of tics. Tics were actually probably always going to show up in this child, but it may make it a little bit worse. And as well as dry mouth. With most of these classes of medications, so make sure that they see their dentist a couple of times a year, making sure they're not getting cavities because of the dry mouth. Non-stimulants, the atomoxetine. If the other ones work up to 80 to 90% of the time, this one maybe work about 55% of the time. So a little bit less efficacious. You can start seeing effects in a couple of weeks, but usually takes about 6 weeks for full effect. So you don't necessarily need to see them back. For the kids on stimulants, we usually see them within a month. And I always tell them, just make sure you call me if there's any major problems before the next time that we see you. Atomoxetine usually start at 0.5 milligram per kilo per day for 4 days because of the GI side effects and the sedation, and you can titrate up to 1.2 mg per kilo per day with a max of 100 milligrams. In one of the studies that they had, there was about a 4 in 1,000 chance of suicidal thinking in kids that took atomoxetine, so it's got a black box warning. I've seen that happen in about 2 kids that I had on it, which was scary for the parents, but really all you have to do is stop it. It's nothing that persists. There was one in that study of like 1,300 kids. There was one suicide attempt, but no successful completions. So it's something we talk about, but it works very well for just a limited number of kids. And then the non-stimulants, also the alpha adrenergic receptor agonists, which is the guanfacine and the clonidine, helps with the kids with the mood lability and tics that can worsen with stimulants. So you might try it in those kinds of kiddos. Be careful, they should not be skipping doses of this one or the guanfacine, because of the rebound hypertension. So just taper off a little bit slowly over a couple of weeks. And then you want to do a cardiac history. You get sedation and dizziness. You can have hypotension and dry mouth for this one as well. In March of 2006, the Pediatric Advisory Committee for the FDA addressed sudden death in kids with ADHD medication. There seemed to be a lot of sudden death going on. So then they were recommending like EKGs for everybody, but then they did a comparison and there was no increase in the amount of sudden death in kids taking stimulants versus the general population. So you don't have to do a cardiac workup on everybody. If they have the family history, or the personal history, having syncope, chest pain during exercise, arrhythmias in the family, things like that, then depending on what it is, we at least have an EKG done, or sometimes we do have to refer to cardiology to get clearance. And sometimes we do it after the fact when they start having palpitations on stimulants, but the medication is working really well. So we usually get cardiac clearance on those, but it's not really a lot of people. And we ask these before starting any medication and once a year as well. So just quickly, we have a 13-year-old boy who's been struggling in school with disruptive behavior and fighting for the past years. He's had a history of ADHD based on his Vanderbilts from school and mom that you're actually diagnosed with, not a history. But he's been on Concerta and he's been switched twice, and he's been on the amphetamine salts. So the methylphenidate was a Concerta. Now you're on the amphetamine salts. You're not seeing any effects. So except for loss of appetite, He's not having any other ill effects, and he's been removed from the class for fighting. So what is the most reasonable next step? Should you increase his dose of medication until he's maxed out? Should you combine 2 stimulant medications? Should you consider that ADHD was the wrong diagnosis? Or should you stop the stimulant medication and start a non-stimulant such as risperidone or clonidine alone? Anybody want to volunteer? C, yes. So if 2 dose increases in medication change don't reduce the core symptoms, then the diagnosis should be questioned and referral or consultation with a mental health specialist is advisable. Stimulants are not dosed by age or weight. Sometimes I've had some little tiny girls on really high doses and big boys on teeny tiny doses. So it works differently on everybody. Metabolism is different. So yeah, this kiddo really needs more of a workup, and you can start the workup yourself. But if you don't feel comfortable, usually I might try 2 of one stimulant to the other side of stimulants. Maybe I'll try the other one if I still think it's ADHD, one of the non-stimulants, but usually if I'm not getting any effects, then I'm thinking this was not the issue. So you guys know about this. If you're having trouble with side effects, are you wondering whether you should change medications, CPAN, register for CPAN? When you guys graduate, make sure you register yourself as well. You can text them now. Have you guys tried texting? If you're busy, there's a number that you can text and say, I have a patient I have questions on for depression medication. Can you call me at 2 o'clock? And they'll call you at 2 o'clock as opposed to I have to have it here and now. Other than that, most of the time you're talking to a psychiatrist within 10 minutes. And it's one of our pediatric psychiatrists around here. And it's free. They do offer for some kids to have an actual face-to-face with the patient. That's a new thing that started in the past year. But before that, it's just talking to you and being a consultant to see, and then giving you resources. You can register your social worker or anybody else in your office in MA, and they can make the phone call for you, or if they just need resources for this person's insurance, they will do all that work for you. So it's a multi-million dollar program. It's like 199 million when they first started. So make sure you use it so we don't lose it. And these are some of the resources, the AAP guidelines, NICHQ down at the bottom, the NICHQ is where you can get the free old second edition Vanderbilt's, not from the AAP if you want to buy the latest one. And chad.org is the other place I talked about. So these were our objectives, and hopefully y'all got something on here. And one of the other things that the AAP recommends, like in their toolkit, is you guys developing your own little system. You know, we've got a lot of this stuff on EMR, but we don't have a good way of getting it on there. It would be nice. There's things like Chattis where you can send people a text and they enter it. It comes up in your chart. Well, UHS doesn't have that, but you know, it's something you could look forward to. We made our own little packets in English and in Spanish. The Spanish are up front. We pull out the Spanish, it's an English one. It's got the teacher forms and whatever. We have an initial and a follow-up package, everything that we would give the parents. Just throw it in the copier and have them take it home until we get a good way of doing everything electronically. So y'all can develop that. Do you guys have any questions? Yes. Do I know exactly what they are? No, but I know it's part of some of the AAP, the guideline on there. I'd have to look at it. Dr. Bliss could probably answer it. For first line, yes, because some parents are opposed to stimulants. And again, that again, same amount, maybe about 50 to 60% likely that it will work. Yes, which is pretty good, right? Right, not as good as the stimulants, but still pretty good. So yes, I've done that in parents that don't want to try stimulants. Yeah.
What's the long-term outlook for the child? How will they be long?
Long-term, so if they get treated early on, there actually seems to be less like substance use and more, you have better relationships more than anything else, right? We don't have good studies, and I guess we would need somebody like, Dr. Plisk or something to look more specifically at those studies for exactly how they do long-term in school perchance, but they do have better relationships with their families and with friends. Because these are the kids that you're not really thinking about ADHD. You're thinking about the inattention and hyperactivity, but these are the little annoying kids that are kind of bothering people and poking and whatever, and nobody wants to be with. So if you can kind of calm those things down, they actually have better relationships with their own families and their peers, and actually seem to have less substance use in the future, versus untreated actually seems to have more issues. They're not graduating school a lot of times, so you'll have a little bit more dropout rate, and then not having very many like long-term job stability, as well as not good relationship stability. So I think we have more evidence for that than the actual school stuff, although we use it more for school and learning as well. Like I said, a good percentage, but we don't know exactly what percentage will continue to have issues into adulthood. Definitely, we think at least 30 to 60% of kids will have it at least through the adolescent years. The hyperactivity symptoms seem to get better than the inattentive symptoms. A lot of times the persisting symptoms are the inattentive.
Sorry, you covered some of this when I had to answer with age, but
Mhm.
for weekends and summers and stuff like that, what percentage of your patients end up with taking a break during those, and how do you decide that?
So again, this requires like an interview. Are they going to be doing anything in that summer? Are they losing a lot of weight? So it's more for the kids that are losing a lot of weight that will do those. Other than that, because part of your diagnosis is you have to have you have to have issues in at least 2 domains. And so, in your home, you're still having issues, and you're still with the brothers and sisters, you're still getting in all the little fights and things like that. Most of the time, and especially if they're driving teenagers, they might need an after school dose, but they definitely need to have it on the weekends. So yeah, it's just really those kids that lost a lot of weight that I get off. Okay. Mhm. So most of the time, so when kids want to taper off in their teen years, it's usually the adolescent that brings it up. Sometimes it's the parent, because they think they've been on the medication long enough and they see that they're getting a little bit better. Honestly, most of the time they've already stopped themselves. If it's a stimulant, you don't have to really taper off per se, because it's kind of wrap it on, wrap it off in a day or so. Some people want to do it that way, but you don't necessarily need to do it. And if they think they're ready, we try it. We just had one yesterday come back after 3 years where he tried it, and he's not doing so great in school anymore. So he wanted to get started again. So I'm okay if they're older and they're teenagers, and like I said, that hyperactivity has gotten better, and it's just inattentive, but their grades are still great. Then again, to me, at that point, you don't have the disorder, or your function is good enough. But at some point you may, especially if you get through the college years, may have more issues. Thank you, guys.
So before you leave, wanted to just give you a little thank you. So were you ever in the U.S. military? If you're in the U.S. military, you're in a unit, you get your unit coin, right? So this kind of marks you as part of the unit. So this makes you an honorary family physician, I suppose. This is the highly sought after, seldom presented, but always treasured family medicine.
Thank you. Beautiful.
Challenge coin. Yeah.
Thank you.
Yeah.
So much to
Oh, it's okay. We did have quite a few. We had 19 participants on Zoom at some points. We had like over 40 people listening today. No,